screen.
Maybe.
Can everyone see that all right?
Yes, it's still
start.
sharing. Oh yeah, there we go. Things like
Does it
that.
work now? Okay.
I couldn't see anything. Couldn't see anything. Oh.
All right. It's going to be with the case 3540, the 41-year-old male.
Okay. This one is another one that came in after I was already down here, so I haven't actually got to meet him. I just spoke to him on the phone. But he's been an active IV drug user since he was 20. He's 41 now. He has been in and out of rehab, but now has since been court ordered to rehab. So it's been a good thing for him though, because since he's been at the new place, he's actually decided to get clean and really try to stay clean this time. So he's communicating with his family and everything. He's got a more stable base now when he comes out than what he did before when he was trying to do recovery. He's really not on a whole lot of medicine. I know we always talk about the PPIs, and he is on Prilosec, has been for a long time. So we'll adjust that to whatever you guys think. He's one of my ones that have been treated in 2008, but had to stop because he went into incarceration halfway through. So he didn't get his whole round of treatment in, and he's still active with the virus. He's had his vaccines. His labs weren't really as bad as I've seen. His liver enzymes were a little elevated, but his APIR was low. He was only like a class A. MELD score wasn't bad. He is vitamin D deficient, so we started him on that. Iron and stuff looks pretty good. He's a genotype 1A, and his fiber source stage was F0. So that's I don't know how he's managed to skate all these years. But we haven't done a liver ultrasound or anything yet, just because he was at recovery point. It's hard for him to get transportation back and forth to these appointments from that place. So I didn't know what you guys thought, where he had been treated previously before, if I needed to do at Plusa this time instead of Maverick, and if he needed an updated ultrasound from since he had been treated recently.
Thank you so much, as always, Mandy. Does anybody have any questions first off?
Hey, Mandy, it's Kaylee. I just had a few clarifying questions. So he was treated how long ago, and he stopped treatment?
He reported 2008, and he only did half of the interferon dose.
Okay.
And I'm not familiar with that medicine, but I'm guessing it would be a 12-week course because it was older. Maverick's kind of new, right? The 8-week.
Yes. So actually, that's super important to ask patients if they've ever reported a prior treatment history, because you're correct. So the direct acting antivirals didn't really come on the market till 2014. I mean, the older PI agents maybe a little bit sooner than that, but any treatment, I'd say safely before 2013, you can expect would have been interferon plus or minus ribavirin.
Yeah, now the other one is about the same situation, and he's ribavirin.
Yeah, it's a completely different mechanism of action. And so that treatment doesn't even matter. Okay. So with he's not had any direct acting antiviral exposure. So it's still important to know what he's been through in the past, or what he started in the past, because those medications in particular, interferon, they're like chemotherapy. They are very toxic medications, a lot of adverse effects. Patients that remember being on them clearly remember being on them. They sometimes were admitted with cytopenias. They could cause bone marrow suppression.
He said he was very tired and very nauseated.
Sure.
Yeah.
But sometimes when you have a patient that's come in and they've had interferon exposure before, they have had a negative experience with it because they had such awful side effects that they are sometimes hesitant to go through treatment again because they're worried it's going to be the same type of experience. And so in terms of retreatment, if he's never had any direct acting exposure, we'd consider him treatment naive. So interferon, ribavirin, even the first generation protease inhibitors, like boceprevir, telaprevir, if any of your patients ever remember being on those agents, those don't even count. So we'd still count him as treatment naive.
Well, good, because that's one of the boxes. On the form.
Yes. So make sure you do check treatment naive on that form rather than treatment experienced. But I will just say, it is important to know the treatment response with those agents also was not great. So sometimes they'd be on treatment 6 months, over a year, and it was a weekly injection. So pretty difficult treatment to complete, even if they were able to, and then success rates were not that great. So, but the bottom line is just that, two things that would matter is direct acting exposure, antiviral exposure, but also just the experience with interferon may cause some of your patients that are coming into care now to have some hesitancy to start treatment because of that prior experience with their Hep C drugs.
Yeah, and he hasn't had any other like major health issues from what we can tell as far as background. But the acid reflux thing is a pretty consistent thing. So what do you guys think about that? Do we need to, Robin told me to ask, do we need to change him to something different than omeprazole while he's taking it, or is he okay?
No, you could do Mavorite for 8 weeks with him, and then you can continue him on his PPI and avoid that drug interaction completely. I would, however, just because of the exposure history that he's had a very long history of risk factors, essentially, for Hep C. Even though his fibro test is F0, this is a gentleman that's had longstanding HIV. His BMI is elevated. He's obese. He has high cholesterol. He's got mild transaminitis. He's somebody that has several risk factors for liver disease progression. So I would still get a right upper quadrant ultrasound on him. I don't necessarily feel strongly that it should preempt his treatment initiation as long as he's really motivated to get started now. But I would make sure you have that imaging modality so you can get a good look at his liver contour instead of only going by the fibro test. Sometimes we have like really discrepant results. The fibro test is F0 and then the ultrasound shows nodular contour, and they're actually cirrhotic. So nothing concerning at first glance, but we just want to make sure that he doesn't need any kind of long-term HCC screening or any kind of follow-up.
Okay.
And then I think the other 2 points I would just touch on, he's a really good case. I think we have good discussion points with him. Just, how long has he been in recovery?
Well, he was incarcerated. I think he said he went in like around 2008. He did a long stint.
Okay.
So he hasn't been out very long to be free anywhere. He didn't tell me exactly what his charges are, but he was in there 10+ years. Gotcha. So he's served a good long time. And when he came out, he tried to do just like outpatient recovery, I think, and that didn't work very well. And then he was at Southern Highlands in-house for a little while, and that really wasn't kicking it. So him and the probation officer, I think, decided that he would do better long-term, and that's what Recovery Point is. It's anywhere from a year to 2. They stay there, they help them get a job, get their stuff together. And that's why I think him having his family come back in, his mom and his daughter, I think it's going to be a big help because he didn't have that before. So
gotcha. Okay, no, that's super helpful. I'm glad you've.
Now, was he clean while he was incarcerated? Well, no, but he was there.
If he's, is he on probation or he's on parole? I'm guessing, and that's what. So, and then I guess that's the other thing is just open discussions with him, since he is in a recovery program right now and he seems to be engaged, but he is, back into the real world really recently. And so I'd have open discussions, like a plan in place if he ends up having to go back to prison, or if he just falls off the radar. He, has to have a way for you to contact him. maybe his parole officer's number, you know, some way that if things kind of fall off, he falls out the wagon, that you're able to continue reaching him, or somebody can let you know where he's at.
And I think pretty much with his case alone, it's if he doesn't comply to this, we're going back.
Yeah.
So I think that whatever charge he called, it must have been a good one. And this time it gave him a chance, and he's grown up a lot too. You know, there's a big age difference when he went in, you know, to hanging out with the party crowd than coming out to probably honestly most of his friends being dead.
Yeah, absolutely. No,
that, you know, that helps a little.
Yeah, no, great case. Thank you. And you know, the didactic today is harm reduction for individuals who inject. And so he's actually somebody that I feel like this would be really applicable to, because you've got someone that's, you know, newly in recovery, has a long history. There's certainly a potential for a relapse risk. And so hopefully some of the things we'll talk about today might be.
I think when he came in March for his physical, and we started all this, because it's just been back and forth trying to get him together. He was at like 80 days clean then. So, and he hasn't lapsed any since. So he's doing better than, he said that this is the longest he's been able to keep it together.
That's awesome. And I think that that's even more of a reason that this is the prime time to talk about risk reduction in the event that that happens ever, because you've got his attention now, and he seems like he's clear-headed enough to accept the information and process it. So yeah, thank you. That's a good case. Who else wants to talk, since it's just me and Mandy right now?
Anybody else anything to say?
Thank you so much. And Jennifer did chat that was a great, you know, case. Thank you so much. It's a very interesting one. All right. You can always put those comments in the chat too. Mandy, you ready for your second case?
Yes. Maybe. No. Okay, this one, I told her I sent the first one in twice because I got confused. There's so much alike. I had to tell her not to duplicate it. But he was another one that was treated in 2010 with that ribavirin. And he actually, it was about the same thing. He was about halfway through his course, got in trouble, ended up incarcerated. When he came out, he never sought treatment follow-up after that, until now. So he's got some other comorbidities going on. He's got thyroid disease now. He was diabetic, but since the weight loss from his recent activity, his A1C has come way down. So he's not currently taking anything for the diabetes right now. His blood pressure and stuff still being active, and he is inpatient treatment as well. He went from Southern Highlands to down in another part of West Virginia. So he texts me quite a bit. He's got his phone and privileges now. He's pretty with it. So he's ready to do this, and that makes it easier. He, just like the other guy, started using in his early 20s and has been active up until he went into long-term treatment. So he did 90 days at Southern Highlands, and he's been down there at Serenity for almost a month now. So we're looking at 120, and he signed up at Serenity for a year. So hopefully I can make him behave long enough to do this. His labs weren't bad either when we went through and did all the stuff. His liver enzymes weren't as elevated as I've seen some of them. He was a class A, just like the other, a low APRI score. MEL score was only 7. He was vitamin D deficient too. So I talked to the doctor at Serenity, and they started him on vitamin D down there to follow up what we already had him on before he left. He was a genotype 3, which from what I understand, talking to Dr. Bailey and stuff, that was the easiest one, which is probably why he's managed to skate so long and not have such awful labs. But with him, it was the same question, because I wasn't sure, should I use the 8-week or 12-week, but you answered that on the last run. So it didn't matter that he was treated with ribavirin. But other than that, he's pretty much the same thing. You know, he's not drinking, smoking like everybody else does. Heavy history of IV drug use and jailhouse tattoos. Guess there was nothing else to do while they hung out. So
Excellent. Thank you so much. So pretty similar. Anybody have any questions with that? All right. Any additional comments for this case?
Hey, I don't know what the verbal equivalent of copy and paste is, but just copy and paste from the last one to this one.
Well, and that's I don't know if they're turning everybody loose in Mercer County now or what, but
But hey, I can always jibber jabber about things. So a couple things. The first thing I looked at, I always get excited about extra hepatic manifestations for Hep C, and you look at his comorbidities, and you see type 2 diabetes, and remember that vicious relationship between type 2 diabetes and Hep C, where Hep C will make your type 2 diabetes harder to control, and type 2 diabetes will make you more likely to progress with fibrosis. So that's bad. It's a bad relationship. The other one's hypothyroidism. And so I'm going to go back on a statement we just made. That may be, this is kind of a funny thought, that may be a gift from his prior hepatitis C therapy, or it could be related to his current hepatitis C. So thyroid disease, pathophysiologically, at least a lot of hypothyroidism is autoimmune in nature, as is a lot of hyperthyroidism. And there's a strong association between thyroid dysfunction and hepatitis C. That's number one. Number two, one of the screwy things that treating people with interferon used to do was, on occasion, it would make their thyroid disease take on a life of its own. So you'd sometimes induce a hypo or hyperthyroidism with interferon-based therapy that wouldn't go away when you stopped it. Interferon was just a creepy drug all around, so it wasn't fun to use. You had 30% success rates. On the last case, you talked about half dose. The reason they did half dose is because usually the patient was getting cytopenias and like chemo. So anyway, bad stuff. But just looking at the thyroid stuff and the diabetes got me excited. Even more motivation to get this fella treated. The first thing that comes up when we're talking about treatment is their genotype 3, which I might have misheard, but it's actually the worst type. So it's surprising that he didn't get more advanced fibrosis more rapidly, especially since he's dealing with almost 15 years or 20 years disease, Lord knows how much. So like Kaylee mentioned before, an ultrasound might be helpful. Ideally, an elastography would be the best scenario. When you talk about therapeutics, genotype 3 are really limited. You got, your Mavorite or your Epclusa. I remember one of your decision points there is if you are cirrhotic or any concerns of cirrhosis and you're going to use Epclusa, you need to do some funny testing ahead of time. So I'm all about being lazy. And so Mavorite would be the easier one to use. There's something I'm going to need Rachel's help on though, and that's this oxycarbazepine. Yeah, that one. It sounds like a seizure pill, and it gets me nervous.
well, that might be one of the ones I think I've had to have the site people change before. I'm pretty sure that's one of them. Rachel normally tells me those things when I call. So my only thing is, like he said that he's like 6'5" and 240 now, but he said he used to be 6'5" and like over 300. So I don't know if it's like you said from the hypothyroidism when he developed that. I'm sure the meth and whatever else he had something to do with that weight loss too. But it brought his A1C down to 5.9. So they're not treating him with medicine right now. So well, at least they'll have to take that pill.
Hey Rachel, want to comment better and more intelligently than my.
Sure. So with the oxcarbazepine here, remember that's one of those 4 problematic anticonvulsants that we see because they are enzyme inducers. So they speed up the metabolism that we see with direct acting antivirals, and it's across the board with all of them, unfortunately, at this time. So the concern there is that we'll have subtherapeutic levels of all the direct acting antivirals, and then we won't get treatment cures because those patients won't have enough of the drug concentration within their body. So it's that one, as well as carbamazepine, phenytoin, and phenobarbital are the 4 big culprits. So it is still kind of contraindicated or not recommended to give them together just because of that concern of treatment failure. This is sort of still a moving target. There's some literature coming out right now about using these, but it's not solidified at this time. So the studies with them are small, and seeing patients being treated while they're taking DAAs concomitantly with these 4 medications. But when I say small, I think the most recent study I saw had like 6 or 7 patients, and so very small at this point. So it's still currently not recommended to use them. So if there is a way to transition him from, I don't see that he has a seizure history. Is this something for like mood stabilization or something like that?
Well, it looks like they started him on that when he went down to Serenity Point. So I don't know if he's developed something while he's been there. I can talk to him and see. But they are really good about, I haven't ran into anybody that wouldn't work with us about changing medicine so they can be treated. So
Yeah. Hopefully it's something along those lines. I know a lot of both patients and prescribers, if it's as an anticonvulsant, so like their seizure medications and it's working, they're very hesitant to change. But for mood stabilizations, it's usually, they can try something else. And
that's what it looks like to me. He's only been on it since May.
Okay.
So I don't have any other field history before then. And that was when he went down to Serenity. So
Okay.
I'm guessing that they have started that probably to make him behave himself.
Okay.
He can be a little pushy sometimes.
All right.
He gets you in the wrong kind of mood. So.
Excellent. Thank you so much, Rachel and Kaylee, John, and again, Mandy, for presenting your cases today.
Mandy, I wanted, oh, sorry, Elizabeth.
I'm so sorry, Kaylee.
I didn't mean, I just wanted to say, Dr. Gilchrist had to step out, but he just wanted me to make sure to clarify that Maverick for 8 weeks, because I know, we assumed you expected, that, but I just wanted to make sure that I said that 8 weeks duration.
And he's another treatment naive too when I go to do my PhD, right?
Yeah, he would be treatment naive. If he were treatment experienced with a direct acting antiviral, then the recommendations would actually be to either do like a Vosevi, which is one we don't really talk about, but we can if that ever comes up, or Maverick for like 16 weeks. So it's a little bit different approach, but when we come in contact with cases like that, then we'll talk about that more.
Okay. Thank you.
Excellent. Thank you, Kaylee, so much. All right, Dr. Fournier, you ready for your case?
Yeah, I am.
Excellent. I'll pull that up.
Thanks. All right. Very good. My patient is a 36-year-old white female who was relatively new to our practice. She had established with one of our nurse practitioner primary care here, and at I think it was their second visit, she had mentioned, oh yeah, I was treated 15 years ago with interferon therapy for Hep C. More testing ensued, and she showed positive for hepatitis C. Her report is that she was successfully treated, completed the whole treatment, and was proven to have had a cure, and then relapsed for multiple years subsequent, and has been clean for over 2 years now. And she said she hadn't got retested, but she kind of just assumed she was positive. But she moved back to this area, and she's out of drug culture now, and wanted to seek treatment. Her other health conditions all are in the behavioral health area, bipolar disorder, anxiety, panic, and those are the meds. Oh, also hypothyroidism, which we just talked about there. She has a history of it, and I don't think she is currently on thyroid replacement. She is currently, she was negative for HIV, hepatitis B, and she has received 2 doses of the Twinrix so far for vaccination against Hep A and B. When we have done her testing. Thank you. Of note, so her liver transaminases are approximately 3 times high with an ALT of 138 and AST of 113. Her other labs are relatively unremarkable, APRI of 0.859 with a child TPU of A and a MELD score of 6. Again, she was HIV negative. Her viral load was 34,900, genotype 1A. Her serum fibrosis marker is F0. She is scheduled for an ultrasound. It's that first week of August. So when we I ordered Maverick for her, and her insurance company has it in a pending status, saying they wanted records from her prior treatment and what the genotype was of her original infection. She actually was treated in our area by a GI doctor who has left the area over a decade ago. She had some records, and the hospital that had took over his practice said they only kept records for 10 years. So we could find evidence that she was treated, but we could not find the genotype, and we have sent that back to the insurance company. And so they came back now and said they want a specialist's opinion as to basically what we should do with her, and they want assurance that she is not going to, what are we going to do to keep her from relapsing again? She had been on Suboxone in the past, and she chose this time not to do it. She felt like that was very difficult to get off of, and she feels like she's committed to staying clean. So I'm not sure if I'm hoping we can get the insurance company to now agree to this. And I was hoping if we send the recommendation from, the team, that would assist her. And the only other comment I'll make is she is one of her mood stabilizers is the Lamictal, and she and her prescriber are fine with her holding that during any treatment because she has other coverage. That's it.
Excellent. Thank you so much. Any clarifying questions? All right, recommendations, please, when you get time.
I will start, I guess. This is Kaylee. I did want Rachel to touch on the Lamictal, because I think I tried to pull it up on my drug interaction app, but I can't get it to load, so I couldn't look that up right now. But I think Lamictal should be fine for her to stay on. I don't believe that that's going to have any interaction. I know it's not a super big deal with her prescriber to change it, but she should be able to stay on that. This is unfortunate because, and you said she's a Medicaid managed care.
Yes. She has, let's see, health plan Medicaid.
What I think, and this is just my honest opinion, I think what's happening is whenever you're submitting the prior auth to rational drug, which, it's a checklist. And as soon as they see prior treatment history, they automatically just go to that retreatment profile. And so you have to have those justifications. I wouldn't even consider her a retreatment. I don't even care. I mean, I do care if she's a reinfection, but I don't really even care if she's a reinfection because that prior treatment history doesn't matter. So you're likely never going to get the prior genotype. You've already looked for that. It'd be great if you could find it, but it's not going to impact her management at this time with direct acting antivirals. So it's more so, yeah, just a letter of support, which I'm happy to provide. Or, Dr. Gilfus could, either one, but just to say, she's technically would still be considered treatment naive. 9 times out of 10, even if you could get her genotype, it would be 1A anyway. And you're still, because that's the most common we're going to see. And then you're still going to treat her as treatment naive. So yeah, that interferon, but I tend to think it's more so, hey, you have to appeal because this checkbox shows treatment experience, and now we're going to have to follow that retreatment algorithm. But yeah, and the plan that you have to play. So the patients that I have had that we have actually had to do retreatment with a direct acting antiviral, there is on the DHHR website, and I could try to send out the form to Mitra and Elizabeth to forward to everyone, but it's like a blurb, and it's basically just saying, you've discussed what plans are in place for that, you've talked with the patient, like to avoid reinfection, what how often are you going to follow up with them? Oh, thanks, Rachel, you're the best. Yeah, so it's just a little blurb. I honestly have it copied and pasted in like a smart phrase in our med record system so that I can pull it in and just ask those questions and put it actually in my note. What our plan is what, we've only done a few times, but is makes it a little bit easier. With her, you shouldn't even have to do that, but if they're now asking for it, you may just have to just kind of cross your T's and dot your I's, but I'm happy to provide any kind of documentation to support that she should not be treated as a treatment experienced patient. Yeah.
Her offering, to you. Yeah, I guess in hindsight, I shouldn't have marked her as a prior treatment. I don't know.
And honestly, she has had treatment before.
She has.
And so, and it's something that, I definitely, there is value to assessing for treatment and history. You need to know if your patients have been treated before. Interferon ribavirin era is not going to impact current treatment recommendations. So I think it's just error with critically looking at the individual case and just kind of checking off a box.
And I guess them paying for it,
Well, but even if I honestly, just because they, a direct acting course, when they're having to pay again for a second treatment course with the direct acting antiviral, that cost certainly comes into play. And that's why they have those stipulations and criteria you have to meet. But with the interferon, it's mainly, I think what they're looking at is retreating with a direct acting course, because the cost with these medications, it's a first treatment. It's not something that prior treatment would have impacted that cost or expense now anyway.
Hey, thank you so much.
Yeah, and regarding the Lamictal, just to kind of piggyback off of what Kaylee said earlier, the Lamictal is actually okay. With either, whether you would go with Mavorite or Epclusa, I don't expect any major interactions with that one, so you're safe. There would be a potential interaction with the Abilify and Mavorite. However, I've had many patients tolerate and do just fine. It's a short course of treatment, so a lot of the times we think with those antipsychotic medications of the metabolic things that go along with those, not worried about that. It's only 8 weeks that they would have that potential exposure. So just watching out for the potential for the CNS depression, as well as some of the what's the word I'm looking for, manic sort of symptoms that can happen, because it does have that narrow therapeutic window of where you want to keep the drug levels. But many patients have taken the two together and done just fine. So just kind of keeping a close eye, and if they, educating them on if you notice any changes in your mood or behavior, you want to be seen. But that's really the only sort of caution or warning, but it's not a contraindication.
Thank you. Yeah, I've had people do well on the Abilify. Appreciate that.
Good. Just one last question, because I always want to make sure, is she on any birth control at all?
No, that's a good point to bring up. She is not, I talked about it with her. She is not sexually active with men. Mhm.
Okay.
Yeah.
Thank you so very much. Any other questions, Dr. Fournier?
No.
And I will tell you, if you're looking for old lab results, sometimes LabCorp hangs on to that kind of stuff. I don't know why. You could try, but they're not gonna have it like on a cross account check. You'll have to actually call in. So, if you know, got time to
Yeah.
fight the phone, but I
Well,
hate the
that
phone
is
plan,
good.
just as an added on. It's one of the worst ones to fight for PA, so you're not alone. It's okay.
Yeah. Yeah, her lab, we actually know where it was done, but well, it was at the local hospital, but it was a send out, and I don't know, they just
Well, if
didn't
it was a
keep
send
up.
out, then it probably went to LabCorp. So that would be I mean, you know, if
That's
you're
true. It
still
might.
adamant, you could try, but they won't have it on a cross account on the system. You'll have to call in.
Okay.
I'm like a detective down here in the county. I have to
Good.
people
Yeah.
I
down.
see that,
like
Mandy.
little super sloop. I'm on Facebook and everything.
I love you, Mandy. That's awesome.
That
Thank
is
you
Gotta
awesome.
be
much.
that way.
Excellent. Thank you guys again so much. As Mitra said in the chat, yeah, we really appreciate all of you. All right, Kaylee, are you ready to present? Did you want me to share your slides, or would you like to do so?
I'm going to try to share my slides
Okay.
because I had a short video, and when I was trying to pull it up before I logged on today, I was having some trouble. So I'm gonna try to do it myself, just so I can hopefully get the video to play. But
I have you as backup, so you're good.
yes, hold on a second though. I got to get out of my stuff. Let's see, have you've shared it with me? Okay. Are you guys able to see my stuff?
Not yet, but mine did take a second, so I don't know, maybe.
Let me see.
You have two screens. Sometimes it like gets confused.
I only have one today. I'm on my computer. Let me see. Oh, okay. You may need to pull it up. How about now? Yes, no, maybe not. Oh, no,
No.
I have to restart my computer. Okay, so,
It's okay. I can share it.
maybe I'll have you share it, Boo. And I might not be able to play the video then, but we'll see.
What the heck?
This is the video. It's because of the video.
Should I just do the?
The YouTube video, but it wasn't pulling up anyway, so we can try maybe from yours, but it might not be able
Should I
to.
just hit enable then?
Yeah, yeah.
Should be okay. Yeah, I think it's just enabling the video.
Okay.
Yeah, that looks great.
Okay. Yeah, so today I love talking about this. I did this talk like, oh, I don't know, a couple years ago. This is we focus a lot on complications from injection drug use, or the potential complications. And I wanted to spend some time talking about ways that we can promote safer practices for our patients who inject drugs. And so this is more so, not necessarily from I guess, yeah, maybe from a patient perspective, and just understanding how the injection process works and trying to identify ways to minimize risk. And so while we're kind of going through this slide set, that's what I want you guys to be thinking about. Our objectives are going to be: recall the concept of harm reduction, identify complications and mechanisms of harm from injection drug use, examine the injection preparation as a means to identify steps to make the process safer, and understand appropriate disposal methods of injection drug equipment. Next slide. Okay, So harm reduction, it's a public health approach that serves as an alternative to abstinence-only guidance utilizing multi-component interventions. Harm reduction should be considered a packaged approach, or ideally a one-stop shop, although that always, we don't always have the capacity or resources to provide a one-stop shop. But harm reduction services include syringe service programs, HIV and viral hepatitis testing, PrEP services, linkage to care, including mental health services, medication-assisted treatment, naloxone, vaccinations like Hep A, Hep B, tetanus, fentanyl test strips, but also safer injection education. And I don't know if we really spend much time talking with patients about how to inject more safely, more than don't share your needles, don't share your works. Utilizing this harm reduction approach really increases the likelihood that people who inject drugs will use health services based on the status of their drug use and not by the status of their disease. A lot of these patients have had poor experiences with healthcare, the system in general. And so they try to avoid a lot of times healthcare until it's actually life-threatening, which is sometimes prompted by the ER visit with endocarditis or septicemia or, limb gangrene. So we really want to try to have that open relationship and open discussions with patients before that is a concern, so that they feel that they're in a safe and trusting, non-judgmental environment, so that we can kind of keep them safe and healthy and alive. Okay. This reduces complications from injection drug use and reduces new HIV and viral hepatitis infections as well. Harm reduction is not an attempt to minimize or ignore the harms associated with drug use. So we're not excusing the behavior by any means. But, again, we are providers and we are here to serve our patients, and our mindset needs to be to meet our patients where they are and not where we expect them to be. And we should be helping them through the process and not helping foster limitations of them remaining our patients. So next slide. Yeah. So several complications, some potentially very serious, associated with injecting drugs. In the interest of time, I'm not going to go through all these because you guys can read, but these are just several complications that you can see with injection drug use. Next slide. And of course, visuals always help. So and I should have prefaced this by saying some of these are graphic. The video I had was somewhat graphic as well, but I think it's important as healthcare providers that, we see things in real life, so we should be able to handle a picture of them. But endocarditis on the valve, that's what that looks like. And then the picture with the red squiggly line that I try to make a circle is a retained foreign body, a broken needle fragment. This beautiful Hep C virus. And then the bottom row are just various pictures of limb necrosis, gangrene, abscesses. The first picture of this gentleman's leg is frank wounds. So the new tranquilizer that's kind of on in the street right now and West Virginia and surrounding states can cause pretty awful looking necrotic wounds. And so that's a picture of that. But yeah, next slide. So mechanisms of harm with injection drug use. I kind of put these into three buckets. Substance related harm. I'm not going to spend too much time on that one because that's actually the one that's in the least control of the individual who's injecting. They can't control necessarily where their supply comes from. It depends on on who's manufacturing it. It depends on who's supplying them, but that tends to be where they have the least control over their own behavior. As we know, fentanyl is in most of the drug supply in West Virginia at this point, over 90%. And so obviously a lot of people aren't intending to. Sometimes it's in marijuana now, sometimes it's in vape pens now. And so really substance related measures to to reduce harm primarily consist of naloxone. So even if your patient says, I'm just smoking marijuana, I still write them for naloxone because they don't know necessarily what's in it. And then fentanyl test strips. And then also making sure that patients have a plan in place when they are injecting. So like not injecting alone, maybe making sure they have a buddy that's with them just in case they overdose, or someone that knows that they're about to inject so that they can call 911 if they haven't heard from them after a set period. There's even some apps available now that patients can download while they're in the setting of injecting. That way, if there's some apps that can like monitor your respirations. That way it can call 911 if there's an overdose, like really cool stuff. So, but anyway, just trying to promote healthier, safer measures for these patients. Next slide. This is the video, and I don't think it's going to work. You can try, Elizabeth, and it's age restricted because it's showing, which I mean, we're all over 18, but it's showing the process of injecting from start to finish. So setting up your supplies, preparing the equipment. It does show a needle going to somebody's arm and then cleaning afterwards. So you can try, but it made me sign in when I tried before.
All right, yeah, let's give it a try. Let me know if you can hear it.
I can hear it, but I can't see it.
Yeah.
Oh, no, really?
I wonder if we can like stop share, re-share like the YouTube video, like the screen of the YouTube.
Can you see it now?
Yeah, I can see it.
Okay.
Yeah, me too. I don't know if there's audio on my end, at least.
Can you hear it?
No, but there's that closed caption.
Yeah,
Yeah.
I can't hear it, but it was more wanting to you to watch kind of the process from start to finish. Because I mean, when I think of patients injecting, I don't really think that I go through the whole process. But I want you to kind of be paying attention as you're watching this gentleman prepare his substance and inject, of all the things that could potentially contaminate this process and put him at risk for various complications. So he's got a cooker. I guess I could commentate, you know, the little tin is his cooker. He's put the drug in there. He's mixed it with water that he's boiled. What he's putting in now is citric acid tablets. So certain substances are too alkaline, so you have to acidify them so that they can liquefy. So now he's got his cotton or filter. So he's trying to draw back the drug without all of the impurities. But when you're watching, making sure all the bubbles are out so that, you know, he's not injecting any air into his veins. But when you're watching this, I mean, you can think about, there's more breaks in the process. There's more breaks in the process that could occur than simply just sharing your works. But you can also see how easy it would be to, so he's drawing back for blood return, making sure that there's blood return, that he's actually in the vessel, and then removing the tourniquet and then administering the injection. So but this video was intended to show, you know, the steps it takes to inject more safely. And I just want everybody to stop and just think about, you know, what our patients might be doing and how what we don't always have access to syringe exchange. So for us to just tell patients, hey, you need to, make sure you're using sterile needles, make sure you're not sharing works. Sometimes that's not feasible. They don't always have, a cooker. The tin that they're cooking with might be a soda can that they've cut in half, that's had the soda that their buddy drank 3 weeks ago. We don't know. And so, syringes, it's not always something that you can get sterile. We would love for them to be sterile. That's not always the case. Water. Some people, I've had patients that were getting water from the river because they just told me, I just didn't care at that point. We have to think of just a lot more than just saying use sterile supplies or bleach your works and don't share. And so that was really the purpose of this talk. We're all already almost out of time. So I might want to stop there because I had a few slides that kind of break down the process more and talk about more specific ways to counsel patients, namely on what their process is and how to identify measures in their personal injecting process where they can be more, safer. So, I mean, some patients, I've had some patients that do a good job of not sharing works, but they're not wiping their skin off with alcohol before injecting, or they think they're doing a great job because they're using tap water. Tap water is not tap water, bottled water. Bottled water is not sterile. And so, we may be thinking, okay, it's in a sealed container. That's good. They're using bottled water. There's still so many contaminants in it. And so I really wanted to spend time to actually go through those steps so that we can better understand how that process works, but also how we can counsel our patients better. But I don't want to start and then, I know we're all have many commitments today. So we can kind of maybe pick up at a different time. But do you guys have any quick thoughts or questions before we get off the call, or personal experience?
I was so glad you did this today, Kaylee, because the other day I was thinking about that talk, that first time you did it. I was so impressed by it and I thought I needed a refresher, so thanks. And what do you guys think about the ethics of this? So a lot of my patients about 6 weeks ago were really disturbed about something they saw about what could be in their drug supply, stuff like rat poison and all these weird things, and they were more disturbed about that than the idea of trank or something like that. And so anyway, that my ethical question is, what would you think about showing them the photo of those complications? That those pictures of the gangrene and stuff were pretty. I mean, some of them have seen that, but some of them haven't. And I just thought, man, if they were that scared by rat poison, they might be equally scared by seeing potential physical complications.
Absolutely. And I think that sometimes we just kind of assume maybe that patients are they expect that if they're doing this behavior, that they know that's just what comes along with it. Some do, but some don't. I mean, maybe they had a friend that had endocarditis, or I'm sure they've had friends or contacts that have overdosed. They might have had that in the past too, but to actually visually see that, and then for us to actually take that step forward and say, this can happen, but here are some things that you can do to help minimize that risk. That says a lot to them that you're willing to make that extra effort with them. And, I think it was important for me to watch the video like that, so I actually could process how everything happens, or kind of the process of it all. But there's a lot of individual steps that we could easily break down and talk about ways that we can promote safer use. But yeah, I think it would be beneficial, Jen, to say, hey, have you ever seen things like this? I actually offer with drug screening now. I know patients that are in MAT or they're following with their programs, they're getting regular drug screens. I'll offer drug screens and say, hey, you've let me know that this is what you're taking. Can I do a drug screen and show you that maybe what you think you're taking may not be what you're intending to take? And you know how many people I've had take me up on that? It's a lot. So
yeah, that's interesting.
Yeah,
You guys can keep discussing. I just want to put the poll up.
No,
So
it's
for
okay.
those that need to hop off, they can.
but yeah, we can continue this later. I just wanted to kind of open that discussion up again, because I think it's important for us to touch on that every so often too.
You know, one other quick comment is that there are also complications from non-injection drug use. I mean, we have one guy who was not injecting, he was snorting, and he completely eroded the bone in his hard palate. And so that's a whole nother, you know, I'm not sure how you prevent that other than not snorting, right? But still, the physical.
Well, but it is one of those things that I think that it's important to, you know, if someone is struggling with substance use disorder, to say, hey, on a hierarchy, okay, injection is a lot more likely to cause you life-threatening complications than smoking. Certainly there's still complications, but you know, smoking or taking something orally has a lot less of a risk than
Sure.
snorting or shooting. So I mean, those are things that we can still bring up as well to kind of help encourage our patients to at least try more safer practices.
I think that I would use those pictures because we have a Gardasil book that we use for HPV vaccines. And to be honest, you don't know how many kids I've got to take HPV shot. You show them those pictures and they're like, oh God. I'm like, yeah. And we honestly use those scare tactics. Or we do a rear review anyway at the high school, but all it takes is one visual of what that could prevent and they're ready to take that shot.
Thank you. Absolutely. It's a great discussion, and we definitely we'll finish off your slides, Kayla. We'll fit that in so we can do the part 2. So think of other comments and questions you guys might have. But my only announcement is the next time we'll meet, as we discussed, Jennifer will be discussing the first half, and then we'll go into didactic with Dr. Gilfus with co-infection and other tick-borne illnesses, which are popping up. So very important topic. So appreciate everyone's time, and I hope you have a great rest of your week and weekend. Thank you.
Thanks, everyone.